During pregnancy, women are at an increased risk for a deep vein thrombosis, which is known as a DVT. Um, Women are also at an increased risk for pulmonary embolism during pregnancy, and this is because estrogen levels increase during pregnancy, which causes an increase in plasma fibrinogen levels, which contributes to blood clotting. Estrogen levels are also increased when taking supplemental estrogen, such as combination birth control pills. This means that the risk of DVT and PE is also increased when taking supplemental estrogen. Estrogen is stored in adipose tissue, also known as fat. Since being overweight means you have more adipose tissue, you're actually at an increased risk of DVT and pulmonary embolism just by being overweight. A deep vein thrombosis happens when there's a clotting of blood within a vein. This could be venous stasis or a hypercoagulation state. It impairs blood flow through the vein and forms a clot. On physical assessment of someone with a suspected DVT, I would look to see if I could observe noticeable differences in size and color of the extremity. Oftentimes, a beefy red swollen extremity is seen with DVT. Venous ultrasonography with or without Doppler is used to diagnose DVT. Sometimes an MRI or a D-dimer will also be used. Hohmann sign is not usually performed because there's concerns about possibly dislodging the clot, and because the Hohmann sign is not a definitive test, we avoid using this. IV heparin is often used until symptoms resolve, and then an oral anticoagulation therapy is started and is usually continued for about 3 months' time. Some nursing interventions that could be expected if there's a DVT would be bed rest with elevation of the affected extremity, compression stockings, changing positions frequently while avoiding sharply flexing knees because that could affect the clot, using moist heat application to the affected area, and frequent physical assessment. A pulmonary embolism can happen when a DVT becomes dislodged and travels to the lungs. This causes impairments in blood flow and gas exchange within the lungs. On physical assessment of someone with a suspected pulmonary embolism, I would look for dyspnea, tachypnea, tachycardia, apprehension, chest pain, cough, elevated temperature, hypotension, diaphoresis, anxiety, change in level of consciousness, and syncope. Usually a ventilation perfusion scan, spiral computed tomography scans, magnetic resonance angiography, and pulmonary arteriogram are used to diagnose pulmonary embolism. An MRI or D-dimer may also be used, and sometimes an echocardiogram is done because abnormalities can sometimes be seen, particularly in the right side of the heart. And a pulmonary embolism is considered an emergency situation, so immediate treatment with anticoagulation therapy starts, and IV heparin is usually used. Supplemental oxygen is often needed. Thrombolytic therapy may be necessary to break up the clot depending on the clot size. If the patient's really anxious, anti-anxiety medications may be needed, and sometimes opioids are needed for pain management. Surgical intervention sometimes is also warranted. Nursing interventions that could be expected for someone with a pulmonary embolism would be frequent repositioning to try to improve the ventilation and perfusion, evaluation and maintenance of their oxygen therapy, pain evaluation and management, and just frequent physical assessments. So usually long-term wise, subcutaneous heparin or some sort of an oral anticoagulant is continued for up to about 6 months after having a pulmonary embolus. Neonatal abstinence syndrome is also known as NAS, and it is a syndrome of withdrawal reactions that might be seen in a newborn baby who's born to a mom who abused drugs. These drugs could be things such as alcohol, tobacco, cocaine, heroin, amphetamines, or marijuana. Symptoms usually involve CNS irritability, respiratory distress, GI dysfunction, and autonomic dysfunction. Some of the signs of neonatal abstinence syndrome include irregular respirations, tachypnea, apnea, nasal flaring, chest retractions, intermittent cyanosis, rhinorrhea, nasal congestion. Neurologic symptoms include irritability, tremors, shrill and incessant crying, hyperactivity or sleep disturbance pattern, seizures, hypertonicity, increased deep tendon reflexes or exaggerated Moro reflex. Autonomic dysfunction includes frequent yawning or sneezing, tearing, excessive generalized sweating. Babies should not sweat. Modeling of the skin, fever. And then there's some GI symptoms we look for also, including abnormal feeding patterns, uncoordinated or ineffective sucking and swallowing reflexes, incessant hunger, frantic sucking, or even the refusal to feed. Vomiting, regurgitation, and diarrhea are also some of the symptoms. So in order to kind of classify the severity of these symptoms seen in these babies, we use the Finnegan NAS score sheet, and this helps guide treatment. Some nursing interventions for a neonate with NAS include supportive therapy to ensure fluid and electrolyte balance, nutrition therapy, infection control measures, respiratory care, swaddling the infant with their legs flexed, and positioning the infant with hands at the midline and arms at the side. We also carry the infant in a flexed position while holding them firmly and closely to the body. We make sure to reduce environmental stimuli, including lights and noise, and introduce only one new stimulus at a time. Rocking the infant in a slow and rhythmic fashion can sometimes help when they're inconsolable or really fussy. Offering a pacifier for non-nutritive sucking can also be beneficial. And we put the infant in a sitting position with the chin tucked down during feedings. And extremely important is organizing care and clustering care so that handling of the neonate is minimized. Sometimes pharmacologic treatment is warranted, and it's based upon the severity of the withdrawal symptoms that the neonate is experiencing.